Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. This morning, the Department of Ophthalmology will be conducting the Clinico-Pathological Conference, and we have an interesting case of a young girl with a glow in the eye. So we have a list of presenters this morning. The presenter will be Dr. Tan Kuan Zi from the Department of Ophthalmology, and we have Associate Professor Dr. Faiza Muhammad Zaki from the Department of Radiology, Associate Professor Dr. Surya Hayati Matpauzi from the Department of Pathology, Dr. Loh Si Kai, a pediatric oncology from the Department of Pediatrics, Dr. Fazina Abdul Karim from the Department of Oral and Maxillofacial Surgery, and Dr. Safinas Muhammad Khialdin, a pediatric ophthalmologist from the Department of Ophthalmology. So without further ado, I would like to invite Dr. Tan Kuan Zi to present the case on this young child. Dr. Tan?
Good morning, Prof. Samsia. So I would like a very good morning to everyone. So I would like to share my slide. So we move on for the case presentations. For the chief complaint, this was a 2-year-old Libya girl with no known medical illness. She was brought by the parents with the chief complaint of left eye white pupillary reflex for 2 months prior to the presentation. It associated with the left eye poor vision for 2 months and also the left eye redness for 10 days. History of presenting illness. Her parent noticed left eye white pupillary reflex for 2 months. It was gradual in onset and became progressively prominent. It associated with the left eye poor vision for 2 months, as the parents noticed the child was unable to reach the toys when the right eye was occluded. It also associated with the left eye redness for 10 days prior to the presentation. There was no eye discharge or eye pain. There was no forward bulging of the eye or squint. No medical advice was sought. The child was still active and able to tolerate orally. There was no history of eye trauma or eye infections. There was no history of NICU admission or oxygen therapy. No history of maternal infection during pregnancy. No headache, vomiting, seizure, or abnormal behavior. No fever, no loss of appetite or loss of weight. The child has no history of past ocular examination or ocular surgery. She did not wear spectacles. She has no known medical illness and she has no past surgical history. For birth history, the child was delivered at full term via spontaneous vaginal delivery. Her birth weight was 3 kilograms. There was no history of birth asphyxia or birth trauma. The child did not receive the complete vaccination in the Libya. However, her mother didn't bring the vaccination book. Her developmental milestones were appropriate for age. There was no history of allergy. For family history, her family moved to Malaysia since October 2018. There was no family history of blindness or malignancy. Her father has no medical illness, and her mother has underlying good control bronchial asthma. She is the youngest of 6. And there was no, and her all other siblings were healthy with no similar ocular complaint. Her family is staying in a rented house in Ampang, and the living cost is being supported by the scholarship from the government of Libya. On general examinations, the child was alert, conscious, pink, and comfortable. Her vital sign was stable, and all her systemic examinations were normal. For the ocular examination, there was presence of relative afferent papillary defect on the left eye. For the visual acuity, the right eye was normal, which was 6.6, but on the left eye, there was no perception to the light. She had a normal head posture and no syndromic phases. The extraocular muscle movement was normal for the both eye, and the eyelid was normal as well. The right eye conjunctiva was white. However, the left eye conjunctiva showed there was a circumcorneal injection with no chemosis. The both eye corneas were clear, The anterior chamber for the right eye was deep and formed, and the anterior chamber for the left eye was deep and formed. There was no hyphema. Hyphema referred to the accumulation of blood in the anterior chamber. There was no rubeosis iridis, which referred to the abnormal blood vessel proliferation along the surface of the iris. And there was no pseudohypopyon, which referred to the accumulation of the neoplastic cell in the anterior chamber. The pupil for the right eye was round and reactive, 3 mm, but the left eye pupil was round, mid-dilated 6 mm, and the pupillary reaction to the light was sluggish. The lens for both eyes was clear, there was no cataract. The intraocular pressure for the right eye was normal, which was 18 mm mercury, but the intraocular pressure for the left eye was high, which was 36 mm mercury. This picture shows there was presence of leukocoria over the left eye. The leukocoria refers to the abnormal white reflection from the retina of the eye. It is seen upon the direct illumination from the fundus through the pupil. However, this was not the real picture for the patient. On the right eye, patient have a normal red reflex, and the optic disc was pink with the cup disc ratio of 0.3. The retina was flat and the macula was normal. However, for the left eye, there was a protruding mass was seen in the which grew into the vitreous and is obscure the details of the fundus. So for the summary, this is a 2-year-old girl with the no known medical illness. She presented with left eye white pupillary reflex for 2 months, associated with the eye redness for 10 days prior to the presentation. On examination, the left eye have no perception to the light with the presence of relative afferent pupillary defect. The conjunctiva was injected and the intraocular pressure was high. There was presence of leukocoria with a protruding white mass seen in the vitreous, which obscure the details of the fundus. Our professional diagnosis at that time was the left eye endophytic retinoblastoma with the high intraocular pressure. We proceed with the investigation. For the ocular investigation, ultrasound B scan was done. It showed a large retinochoroidal mass which grew into the vitreous and occupied 2/3 of the left group. No extraocular extension seen. For the systemic examination, full blood count, renal profile, and the liver function tests were normal. For the full blood picture, there was no significant abnormality detected. There was no leukoerythroblastic picture. There was no blast or abnormal lymphoid seen. For the immediate management, in order to control the intraocular pressure for the left eye, we have started the intraocular pressure lowering agent, which was topical brinzolamide 3 times a day and topical latanoprost once at night for the left eye. And the child was scheduled for the urgent contrasted CT brain and the orbit and the urgent examination under anesthesia under GA.
Thank you, Dr. Tan, for the brief introduction to the case. Before I proceed to the next speaker, perhaps Dr. Tan would like to enlighten the audience about the significance of the history on NICU admissions and oxygen therapy and history of maternal infection during pregnancy. Why are those history important?
The history of any maternal infection during pregnancies is important because, for example, the tortuous infection, and it is significant as the tortuous infections and is a risk factor for the congenital cataract. And also, any history of prematurity, NICU admission, oxygen therapies is important as well because we have to rule out any differential diagnosis of retinopathy of prematurity.
And all these causes can cause leukocoria, yes?
Yes.
Okay, good. All right, to present to us on the CT scan of the brain and the orbit, which was done around May last year, I would now like to invite Dr. Chai Jia Ning from the Department of Radiology to share with us the findings on these images. Dr. Chia?
Thank you. Thank you, Prof. Good morning, everyone. I'm Dr. Chai from Radiology Department. And now I have CECT, which is a contrast enhanced CT orbit performed in May 2019. On the left-hand side here is the coronal reformatted image, and on the right-hand side is the axial image. So we can see from these two images, there is this heterogeneously enhancing lesion seen within the left eye globe, and on the axial we can see that the main bulk of the lesion is located rather posteriorly, and there is no obvious extraocular involvement this time. And these two images showing that within this lesion, there's area of calcification, which is a very hyperdense area that you can see in the soft tissue window as well as in the bone window. So these two images showing that the left optic nerve is symmetrical to the right, and there is no enhancing lesion in the left optic nerve. So this is the coronal image, and you can see the left optic nerve and the right optic nerve is symmetrical, and there is no mass or lesion or enhancement noted within. So at this point, the left optic nerve is not involved. For the imaging differential diagnosis for patients presented with leukocoria, you can see that the highest percentage of the patient is actually eventually diagnosed with retinoblastoma, and usually within less than 5 years old, and it can occur bilaterally in 20 to 30% of the cases. So the size of the affected eye globe is also important to us, because for retinoblastoma, usually the affected eye globe size is still normal, but for other conditions such as persistent hyperplastic primary vitreous, retinopathy of prematurity, they have small eye size. And the very important feature is calcification. So if we see images of a patient, we have an intraocular lesion bilaterally and calcified, and retinoblastoma is to be considered. And this is my reference. Let me stop the screen sharing.
Thank you, Dr. Chai. I was just wondering if you have calcification on your CT scan images, and you mentioned that the differentials would be, one of it will be retinopathy of prematurity, and the other one was what again just now?
It's a very rare tumor.
Right.
Yeah.
Would there be any difference in the soft tissue surrounding features of calcification in the eye to differentiate between these three conditions?
First of all, the calcification to occur in the retinopathy of prematurity is actually very rare. So if you see a calcified lesion, it's already pointing to us that this is most likely a retinoblastoma. So of course, the retinoblastoma has enhancing soft tissue tumor, and the retinopathy of prematurity, sometimes they do not have so much of enhancement.
Okay.
And there is another very rare tumor which sometimes very difficult for us to differentiate imaging with imaging wise. So we need a HPE.
Okay. All right. Thank you, Dr. Chai, for the enlightening images. I'll now call upon Dr. Tan to continue with her presentation.
Okay, thank you, Prof. Nosamsia. So we scheduled the patient for the examination under anesthesia under GA. The examination under anesthesia under GA was performed with the portable slit lamp, binocular indirect ophthalmoscope with the indentation. Over the left eye, the lens was clear. There was no rubeosis iritis. However, the intraocular pressure for the left eye was high with 33 millimeter mercury, and the intraocular pressure for the right eye was normal, which was 16 millimeter mercury. This is the fundus picture of the patient. There was a total exudative retinal detachment touching the posterior lens capsule, And also there was presence of 2 whitish retina mass. One of the retina mass was located at the inferior nasal retina. It was about 3D diameter in size and the borders are seen. Another smaller whitish retina mass was located at the superior temporal retina and the size was about 2D diameter. This was a 360 degree of the subretinal seeding seen. The pediatric oncology team proceeded with the lumbar puncture and the bone marrow aspiration. Cerebral spinal fluid was clear in color and negative for the malignancy. The bone marrow aspiration showed there was no tumor clump or infiltration and no excess blast. The 3 fine biopsy showed there was no evidence of metastatic infiltration. So our final diagnosis was left eye endophytic retinoblastoma grade E with the high intraocular pressure. We proceed for the urgent left eye enucleation under GA. Intraoperatively, all the 4 rectus muscles were identified and pre-placed suture applied with the Vitrea 6.0 and cut the muscle. The oblique muscle was cut as well. The group prolapsed and the optic nerve cut was about 12 millimeter long and the orbital implant was inserted into the orbit and the conformer was inserted.
Okay, thanks, Dr. Tan. What made you grade this patient as grade E?
Because this patient has the extension, the tumor has the extension to the anterior chamber with the posterior lens capsule touching. And based on the classification of the international classification of the intraocular retinoblastoma, it falls under grade E.
Okay. Will that indicate a good prognosis, bad prognosis?
Yeah, for the grade E retinoblastoma, it indicates a very poor prognosis.
Okay, all right. I have a question from the audience from Prof. May. She asks she said, good morning, may I know if any MRI brain was done and are there any findings?
For these cases, the imaging pre-operatively is only the CPC contrast, and the MRI brain was done after the operation, and there is some findings in the MRI that we will come present later.
Okay, all right. Thanks, Dr. Chai. Okay, I will now proceed to invite the next presenter, Professor Madhya Dr. Suryahati from the Pathology Department to explain to us or to discuss with us on the histopathology of the examination of the left lobe.
Okay, thank you, Prof. Shah. Okay, Assalamualaikum and good morning. Thank you for inviting the Pathology Department to participate in the CPC. I will now share my screen. Okay, so after the surgery, we received the left eye globe in the laboratory. So macroscopically, we received a left eye enucleation specimen that measures 30 times 22 times 22 mm, maximum 3 cm, with an optic nerve attached, and then the optic nerve measures about 12 mm in length. Okay, cut section of the eye shows an endophytic tumor mass that occupies the vitreous cavity. The anterior chamber is clear, and this tumor measures about 1.7 cm in maximum diameter. Okay, there is no gross extension to the optic nerve that we can see on gross examination, and the tumor is seen 12 mm from the optic nerve resected margin, and there is no gross extraocular spread seen. Okay, so now we go on to the microscopic examination of the left eye. Okay, before I move on to the patient's histopathology features, I will explain first the morphology of tumor in retinoblastoma. Okay, the retinoblastoma arises from photoreceptor elements of the retina. Therefore, under microscopic, the tumor can show photoreceptor differentiation, and the morphology for each tumor depends on the degree of differentiation within the tumor. Most of retinoblastoma are undifferentiated. Okay, so the undifferentiated cell looks like this, small round cells with scanty cytoplasm. There is no rosette formation. Okay, and when the tumor is differentiated, it forms rosettes. Okay, there is some rosettes that can be seen in retinoblastoma. First, we can see photoreceptor differentiation, or we call it flexner intestinal rosette. So how does it look like? Okay, so you can see here the flexner intestinal rosette is a tall columnar tumor cell. The rosette is formed by tall columnar tumor cells surrounding a central lumen. Okay, we can also see neuroblastic differentiation or hemorrhoid rosette. So in hemorrhoid rosette, the tumor cells surround a central cytoplasmic extension. There is no lumen per se in hemorrhoid rosette. And hemorrhoid rosette is an infrequent finding in retinoblastoma. Hemorrhoid rosette is mainly seen in neuroblastoma and medulloblastoma. Okay, so other rosette that can be seen in retinoblastoma is florets. So in florets, we can see presence of bulbous cellular extension of tumor cell here at the arrow. And this actually resembles photoreceptor inner segment, a normal photoreceptor segment. Okay, so now we move on to the patient's tumor. So this is a low power view of the tumor. We can see the tumor is composed of sheets and nests of undifferentiated tumor cell interspersed by small blood vessels. Okay. On higher power view, the tumor shows is composed of small round cells, blue cells with high nuclear cytoplasmic ratio. We hardly see the cytoplasm. The cytoplasm is very scanty. Okay, in other areas, we can see flexner intestinal rosette, which is the composed of tall columnar cell surrounding a central lumen. Okay, and this is the blood in between the tumor cells. Okay, in other areas, we can see hemorrhoid rosette, which is a tumor cell surrounding a central cytoplasmic extension. There is no proper lumen in hemorrhoid rosette. Okay. And we can also see the tumor has infiltrated the choroidal layer of the retina. Okay, this is the normal choroidal layer. You can see brownish pigments. Okay, in the retina choroidal layer, and this is the tumor cells. At this area, the tumor cell has not infiltrated the choroidal layer, but at other areas, you can see the tumor has infiltrated the choroidal layer. Okay, and the choroidal infiltration is massive, more than 3 mm. You can see here, this area marked by green ink. The tumor has infiltrated the choroidal layer and the length is about more than 3 mm. And massive choroidal invasion more than 3 mm is one of the high risk factors in retinoblastoma because the patient had high risk of metastasis. Okay, so this is the optic nerve. Okay, the optic nerve is clear. The tumor just abutting the posterior end and has not yet infiltrated into the optic nerve. Then the optic nerve margin is of course clear. Okay, we do further stain. Retinoblastoma is positive for synaptophysin. Okay, so as a final diagnosis, we conclude that this is a retinoblastoma with massive choroidal invasion present. So the stage shift about P is PT3A because she has massive choroidal invasion more than 3 mm, and the optic nerve margin is free from tumor. Okay, I think that's all. Thank you.
Thank you, Prof. Surya. Can I just ask what is the significance of this staining with for synaptophysin?
Okay, retinoblastoma is usually positive for synaptophysin. In this case, we usually do several LHC to exclude other small round cell tumors. But most likely it is retinoblastoma because it occurs in the globe, in the eye.
Right. And small round cell tumor would be not in the eye?
Okay. In the eye, usually retinoblastoma. Okay. Other small round cell tumor include rhabdomyosarcoma, neuroblastoma, yeah. But it's not in the eye.
Okay. So to my lovely master student, that this would be living evidence of what you have read all this while in the books. All this while, you've just read about intestinal and hemorrhoid and all that. But you would never forget these photos once you see them, I hope. Okay, the next speaker would be Dr. Loh Si Kai from the Department of Ophthalmology. She is the pediatric oncologist and she would present the findings on chemotherapy for this patient. or discuss on chemotherapy for this patient.
Thanks, Prof. Samsia, for your introductions. I'm Ro from Department of Pediatrics. Yeah, I'm going to share with you in terms of the management, oncology management of a child with neuroblastoma. Briefly talk about the diagnosis and grading that will help you to understand the treatment strategy that we are taking. And I will just mainly highlight the role of systemic chemotherapy in retinoblastoma and briefly touch about a possible aspect, other aspect of retinoblastoma management. So as you can see on previous presentations, this diagnosis of retinoblastoma a bit different from other cancer or other tumor. Biopsy are not required, as a biopsy may cause harm to the patients and will affect the patient's visions. So diagnosis can be made mainly by EUA examination under anesthesia by our ophthalmologist colleague. MR and CT are useful or helpful for diagnostic purpose and mainly to look at extensions of the tumors, whether the tumor extends beyond the globe. And for metastatic purpose, most of the patients or all patients who will have a retinoblastoma will perform a bone marrow and a lumbar puncture to look at the extent of the metastatic lesions from retinoblastoma. Bone scan may be done if you have quite a massive extraocular disease. So this slide I'd like to show mainly the international intraocular retinoblastoma classifications. There are a few staging or grading that you can use, but in general, this IIRC is a widely used approach locally and internationally. And most of the time for clinical part of it, before we initiate any treatments, we'll use these to guide us in terms of what treatment modality that we want to choose. So basically, just this classification or this grading are mainly for the disease that confine to a group or intraocular disease only. So the show here, the show here is a grade A and B are mainly tumor confined to retina only. C and D are the tumor have extend beyond the retina, mainly with a subretina or vitreous seeding. And group E, can see here, those tumors extend beyond that towards the anterior chamber, or those with specific features like in our patients with a glaucoma is considered grade E. Just to try to highlight here is most of us may have forgotten or to recap on the structure of the globe. So neuroblastoma mainly arising from retina, which is the photoreceptor area, and the outer area from the retina are the choroid area that supply the blood supply. You can see on your HB slide that Prof. Surya highlighted, and the outermost is the sclera of the globe. Innermost, inner layer from retina are your vitreous area, and you go anteriorly is your ciliary body, lens, and anterior chamber. So, this retinoblastoma will grow anteriorly, or it may grow if you don't detect early, it may grow beyond the intraocular area. So when you have a child with a retinoblastoma, before we initiate the treatments, we have to see whether is this just an intraocular disease and what's the grading, or this disease or this tumor have extend beyond the ocular, whether the tumor affect only one eye or affect bilaterally. As in our patient is a unilateral disease, grade E. So the aim of treatments, most of all, it's important that we want to eradicate disease and save life and to prevent the disease from recurrence. And if, other than that, if you can do more than that, we wish to salvage the visions, which is not possible in our patients, or we wish to salvage growth, means that we want to prevent enucleations if possible. All right. So what are the treatment options that we have? Although it's intraocular tumor, other than a local modality, you have local therapy. I guess ophthalmologists will explain a bit more. Mainly administered by ophthalmology during EUA. It can be cryotherapy or laser therapy. This intraarterial chemotherapy, you need expertise, which we don't do it routinely, or we have some limited experience in our center. It's mainly done by interventional radiologists. They infuse chemotherapies targeted to the tumor. It seems to be an effective way of shrinkage of the tumors, right? And you have intravitreal chemotherapy, or you enucleate the whole tumor, or you may require radiotherapy in some cases. Or although it's intraocular, there is a significant role of systemic chemotherapy which I will explain later in my slide. And very importantly, when you have a child with a retinoblastoma, you need a multidisciplinary kind of approach to decide on where should we go for this child. So this one to highlight here is, as what our patient has, you have intraocular disease. So you ask yourself whether can we salvage the globe, or is it salvageable? Unfortunately for our patients, a grade E disease, which is non-salvageable. So the child ends up with enucleations. So enucleation basically are done for those with grade E disease, or some or significant portions of grade D disease that not possible to shrink the tumor returns in the modality I'll talk about later. And this patient also have high-risk pathological features, as been highlighted by Prof. Surya. So in short, that this patient have a left eye intraocular grade E with a high-risk HPE. So he will need to go on with further adjuvant or systemic chemotherapy. He received total of 6 cycles, and this is to prevent the recurrence of the disease. All right. So how about for those you have a patient that you're able to salvage a group, usually it tend to be a less lower grade A, B, or C. For role of systemic chemotherapy, basically we use for all patients with group B and group C. And the main aim for systemic chemo are to shrink the tumor. And a lot of times we work together with ophthalmologists that you need a recurrence or many cycle of systemic plus the local therapy for you to successfully shrink and so-called cure the tumor locally. And for group B and group C, with this method, you have a very high chance, almost more than 90% success rate on salvaging the group and treating, curing the disease. Again, if the disease are not responding, you can add on intraarterial, intravitreal chemotherapy, or talk about second-line chemotherapy. So this cycle will go on for 6 cycles, sometimes up to 9 cycle therapy, in order to be successfully treat the disease. In other way, that if the disease progress or not responding, it may end up with enucleations. All right. So this is a way we approach intraocular disease. For bilateral disease, again, in general, we have to evaluate carefully, and most of the time, we'll look at the eye with more extensive disease to make the choice whether are we going to give a systemic chemo or how we're going to approach this child. Sorry. So for those extraocular but no distant met, again, the role of chemotherapy are very important as a neoadjuvant to shrink the tumor in order for ophthalmology to enucleate the eye, and followed by further systemic, and you will need orbital radiotherapy in this kind of conditions. And you can see the intraocular disease, radiotherapy are not needed if there's no optic nerve involvement. So for the chemotherapy that this child received, or in general, the chemotherapy that we use for the condition that I explained above, combinations of 3 drugs, carboplatin, etoposide, vincristine, and all these 3 drugs are administered on one day, or first day of the chemotherapy, and the cycle will repeat every 3 weeks. So before each cycle, the ophthalmologist will examine the child under EUA, and the local therapy will be given as what required by the case basis. So most of the patients with retinoblastoma, they are young, and a number of them are infants or less than 2 years of age. So when we give a chemotherapy, we have to consider what are the potential side effects that the child will are subjected to. So in general, the general side effect from these three combinations of chemotherapy are myelosuppression, means that it causes neutropenia, HP, and anemia and thrombocytopenia. But good thing about it is most of the time it only causes mild to moderate myelosuppressions. Very rarely they go into a severe sepsis or severe side effect, and some degree or no degree of nausea and vomiting and alopecia, which these patients experience. And these patients only have 1 or 2 episodes of febrile illness that are uncomplicated. And also, these patients are very young. When you give a platinum group, carboplatin, we have to monitor closely the kidney and hearing, especially those infants. They may have a very high risk of getting a ototoxicity and nephrotoxicity for these group of patients. Just a bit on the metastatic disease. A bit sad if the patient comes with a metastatic disease, you need to treat them much more extensively. And again, you may need an autologous transplant. It shows that it's effective in these conditions, and radiotherapy and nucleations. But all these treatments are very toxic for a very young child. And also those CNS involvement, you can add in intrathecals or cranial spinal radiation, which can require high mobility, mortality and mobility related treatments. So in short, briefly, intraocular disease are curable, excellent outcome. If you have extraocular extensions, the outcome are half. Sorry. Yeah. And if you are a metastatic disease, we said that outcome is dismal. All right. So in general, that's all about the ocular or the tumor treatments. But when you treat a retinoblastoma, it's something to highlight is you may want to think of some other aspect of these disease-related problems. One of it is it can be a heritable disease where you need to do genetic counseling, screening, or talk about later malignancy in this group of patients, or you think of the late effect that this child may carry for life, where you nucleate too young or give radiations at very young age, you're going to have these disfiguring features where the orbital growth will be affected. It means that one eye will look smaller compared to the other. If you manage to salvage the growth, also you may have a long-term complications like vision, strabismus later on to handle, and also carboplatin ototoxicity that you want to bear in mind. I think that's all. Thanks.
Thank you, Dr. Loh. Can I just ask this ototoxicity and nephrotoxicity, are they reversible?
For ototoxicity, unfortunately, it's not. So most of the time, we will monitor them closely. Once they have some mild, mainly a high pitch impairment, we need to adjust the dosage and monitor it closely. Yeah. Okay. Usually we don't wait until it gets severe or require hearing aids. We have not seen any such cases. So usually pick up very, very early.
So they would normally have a serial hearing assessment.
Yes. And for our girl, these patients, she don't have any problem with this carboplatin toxicity.
Okay. Thank you, Dr. Loh. That was very enlightening to us. Now I would like to invite Dr. Fazlina Abdul Karim from a maxillofacial surgeon from the Department of Department of Surgery to explain to us on ocular prosthesis in this patient. Dr. Fazlina.
Yes, thank you, Prof. Sham. Thank you for inviting me. I am Fazlina Abdul Karim. Actually, I'm not a surgeon, but then I'm helping my surgeon colleague by doing a replacement or reconstruction or rehabilitation of the missing part or organ. So for this case, what I helped Dr. Shafinas when she contacted me for this unfortunate girl case is I'm doing an ocular prosthesis. So as we know, the ocular and orbital prosthesis is a type of maxillofacial replacement or prosthesis, and is an extraoral prosthesis. So why we need to do the ocular prosthesis is for the purpose is to prevent the tissue in the eye socket from growing to fill the empty space, and also to prevent from the tissue collapse and turning inwards of the eyelid. And then what we do normally, we will collaborate with ophthalmology teams by doing examination, impression taking, trying in the ocular wax pattern, and also do iris painting, and we give or issue the ocular prosthesis under general anesthesia, because as we know, children hardly can cooperate with us in the clinical setting. So this is the equipment or the material that I bring into the OT, in the OT setting. What we do normally, first we will do the ocular tray selection, and then we will take impression with alginate material impression using the ocular tray to get the mold of the socket. And then the impression material will be transformed into a wax mold. And after that, we will take the wax mold and do a try-in, the wax pattern to see the bulging, to see the position, and to see the fitting of the final. This is to present the final prosthesis later on. And then in the same setting also, we select the iris button according to the non-defect side or the other eye. According to the diameter of the iris of the non-defect or the other eye, and then we do the iris color painting using the dry earth pigment color. So there is an artistic element here. We try to get as similar as we can, and after that, we bring to our laboratory, dental laboratory in our clinic, and then we do the processing of the ocular prosthesis. This is the step. The final product will be like this, and then we do the sclera painting before we do the polishing, and this is the final outcome of the ocular prosthesis. And then after that, we will join back ophthalmology team to issue or to give the ocular prosthesis also under general anesthesia, as we know that we have a difficulty to sit children on our dental chair to do the insertion or removal of the ocular prosthesis. And then this is the view of the patient in the ward after or post GA. So this is upon review, this is the outcome for the children. Okay, and slowly it will adapt, it will try to adapt, and we need to teach the parents, we need to teach the parents how to remove and how to insert the prosthesis, and also maintenance and cleaning wise. Okay, this is other patient that I just want to show the move. There is a movement of the ocular prosthesis, but very limited. So, up, down, left, right, very good. Up, down, left, right. Okay. Up. Okay, this is, even though there is no vision, but then at least that the movement give a little bit of natural appearance to the patient. And this is the example of other ocular prosthesis in other children. I hope that by teaching the parents and also the children by inserting, I hope that this source of video can show and give what we call cooperation letter for the patient, because they need to wear the prosthesis for their lifetime. Okay, thank you for now.
Thank you, Dr. Fazlina. Just a quick question. This eye movement, this prosthetic eye movement, will it improve with practice if the child, every day try to look at that up, down, left, right? Will it improve or not?
Actually, it's just to help patient to adapt. It's a quick adaptation for the patient because sometimes they feel there is a foreign body in the socket. But then because of patient wearing the conformer instead of the ocular prosthesis before we construct the ocular prosthesis, so some of the patient already adapt with it because there is not many different. It's just a matter of the features and also the thickness of the prosthesis is different.
So when they adapt, they would not feel there's a foreign body in the orbit, yes?
Yes. Yes. It seems like we wear denture because of course few weeks to few months sometimes patient have a difficulty to adapt. Similar with other prostheses.
Right. And how often do you advise them to clean the prosthesis? Is it a daily thing that they have to remove and clean?
Yes, Prof. They need to remove it every day. My suggestion, normally they wear it during daytime, and at night before sleep they can change it into conformer.
Oh, they still have to put something in the eye when they go to sleep. What if they don't? Does the orbit shrink?
Yeah, there is a possibility for the long time of period or duration of time they're not wearing anything inside the eye. There is a possibility of the eye not shrink, but then it will have a problem on the fitting of the prosthesis later on.
Right. And because this is a child, as they grow, do you change the size of the prosthesis?
Yes, of course. Normally, it can long last up to 5 years, but then most of the time, I need to change it quick because there is a issue of lost prosthesis. And also changes in color, in the iris color.
I see. Okay. All right. Thank you, Dr. Fazlina. That is very interesting to see our prosthetic colleagues help work with us. I think now we're going to go back to Dr. Tan to describe on the progression of the patient.
Thank you, Prof. Sham. So for the progression, after completed the chemotherapy, patient have the MRI brain and the orbit done on the November 2019. It shows suspicious finding of recurrence with the enhancement of the perineural portion of the left optic nerve. However, the repeated MRI showed it was just post-operative changes with no evidence of recurrence. And patient also have the regular EOA done every 4 to 8 weeks after the operation to evaluate for the tumor recurrence. And the last EOA was done on the March this year, and it showed that there was no sign of tumor recurrence. Thank you.
Thank you, Dr. Tan. So now we shall go back to Dr. Chai to present to us on the CT scan findings.
Okay. Let me share my screen. So this is the post-operative MRI, the first MRI done after the operation, which is in November 2019. I put up 2 images, which is a T1 weighted post-contrast study with fat saturation in the axia as well as in the coronal view. So you can see that the left eye globe is no longer there, it's absent because it's surgically removed. And the residual intracorneal left optic nerve is this one. And around this left optic nerve, there is this enhancement noted. We call this perineural enhancement. The enhancement, there is no nodularity and there is no mass-like lesion noted. So the extraocular muscle that I am outlining here are symmetrical and homogeneous. And to compare the left optic nerve, this is the right optic nerve for comparison. So there is no enhancement around this right optic nerve. So there's present no perineural enhancement in the residual left optic nerve. So it can also be seen in this coronal image. This is the right optic nerve and this is the left optic nerve. And around this left optic nerve, there is this perineural enhancement. Because this is the first MRI post-operative, and we are not very sure whether this is a residual tumor or this could be just post-operative changes. So we do a follow-up on this patient in a serial MRI. So you can see that in March 2020, as well as this is the latest MRI, which is in September 2020, the perineural enhancement noted around the residual left optic nerve is similar. There is no increase in size, and there is no nodularity noted. Okay, and there is no mass-like enhancing lesion within. So the rest of the MRI imaging finding also show that there is no intracranial extension or any intracranial tumor. So because of this serial MRI, it shows the stability of this perineural enhancement. So these are most likely to represent post-operative changes rather than a residual tumor. And from the HPE just now presented also, the left optic nerve is not involved. Okay, that's the end of my sharing.
Thank you, Dr. Chai. Just a quick question. When you say there's enhancement seen around the perineural area and it's not related to a tumor recurrence, does that mean that this enhancement enhances fibrous tissue that has occurred around the optic nerve?
Yes, it's either fibrous tissue or granulation.
Right.
But at the first MRI, when we are at the first MRI, first post-operative MRI, we are not very sure whether that is the residual tumor or just the post-operative changes. But across the time, we are confident that it is a post-operative changes rather than tumor recurrence, because we expect tumor to be more nodular with time, as well as an increase in size.
So fibrous tissue can be enhanced, and if it does enhance, it will enhance throughout, forever, or will it be less enhancing as it progresses?
Sometimes it can enhance for quite some time, 1-2 years, or sometimes it can always enhance in the subsequent follow-up of the MRI. So we're not very sure, but the thing is, they usually don't grow in size for granulation tissue or post-operative changes. Anything that grow in size, or we found that there's new restricted diffusion inside the perineural enhancement, then we have to raise the suspicion on the local recurrence.
Okay, thank you, Dr. Chai. We have a question from Prof. Nolia, who asked whether the surgical margin of the excised eye was cancer-free. I think Dr. Safinas will answer this question when Dr. Safinas is going to present next, so she will answer this question. Dr. Safinas, I'll now invite you to present on the overview and also answer Prof. Nolia's question.
Okay, Assalamualaikum and good morning. So the surgical margin, basically the optic margin was free of the tumor, to answer that question. So I will give an overview basically for the benefit of the medical student regarding our case, which is a retinoblastoma. So retinoblastoma is the most common malignant intraocular tumor in children. The incidence is about 1 in 20,000 live birth. There is no sex or racial predilection, and actually is overall good prognosis, about 98% survival rate, especially if cases are detected and treated early. In retinoblastoma, the mutation occurs on the RB1 gene, which is located on the chromosome 13q14. This is very important for our students to remember. And this hypothesis of the Knudsen-2 theory, where both copies of the gene must be mutated in order for the tumor to develop. So in retinoblastoma, there's 2 types. There's hereditary and sporadic. So in hereditary retinoblastoma, the child would receive one mutated gene already from the parents. So they have the mutation prezygotically. So the second mutation occurs postzygotically. So they are more at risk to develop the tumor compared to a child who has sporadic RB, where both the mutation occurs post-zygotically, so there is less chance for them to develop the tumor. So the clinical presentation, leukocoria is actually the commonest. About 50 to 60% of patients would present with leukocoria, which, as Dr. Tan has mentioned, is an abnormal white pupillary reflex, and it's seen with naked eyes. We do not need any special instruments, and we can also see this in photos of the child. There are other differential diagnoses of leukocoria, but because retinoblastoma is the life-threatening condition, we really need to rule out this cause first. The other causes which are more common is cataract, either congenital or developmental, and rarer causes include severe retinopathy of prematurity, persistent fetal vasculature, Coats disease, ocular toxocara, but these are rarer causes. So what are the other clinical presentations? They may present with a squint. They may have ophthalmos when the intraocular pressure is high for a long time and cause the globe to be enlarged. And when the disease has advanced to the anterior chamber, they may have pseudo-hypopyon where the tumors sediment in the anterior chamber. And in very advanced disease, if they present quite late, they may have orbital inflammation or even orbital invasion. So when we do EUA, this is what we see. So we may see multiple smaller tumors at the periphery, which may spare the macula. So in these cases, the vision could be preserved. There may be one large solitary tumor at the center or multiple large tumors. And in advanced cases, they may have retinal detachment, subretinal seedings as in our patient, and vitreous seedings where we see the seedings in the vitreous. So as mentioned as Dr. Loh, there is two classification. One is for intraocular disease where the disease is still confined in the globe, and we have extraocular disease. So grade A and B is for local tumors, and C and D when there is seedings, subretinal or vitreous seedings. And grade E is actually when the eye is almost destroyed anatomically or functionally, when there's lens starch, IOP is high, the tumor is very massive that it goes into the anterior part. We also have this extraocular classification that we need to know. We use the International Retinoblastoma Staging System, where this would depend on whether there is any regional extension. If this is in stage 3, for example, there's already a lymph node extension. And that's also why it's important during the EUA that we also do the lumbar puncture and the bone marrow, because it will show whether there's any metastatic disease which has gone into the hematogenous spread or into the CNS system. Okay, for management of patient, our first aim is, of course, to preserve life. And if possible, we try to preserve the globe. And if patient is fortunate enough, we may preserve the vision. And in retinoblastoma, it is always a multidiscipline approach. I'm very fortunate to have very good colleagues that we are managing RB cases together. Whenever I get a case, I would surely call Dr. Loh and Fazlina, telling them that we have our RB case ongoing, and of course Prof. Aiza in radiology. But so just to reiterate how we treat intraocular tumor. So basically it's based on is unilateral or bilateral. For unilateral mild cases, group A and B, we give local therapy. But for the advanced cases, in Malaysia, we still do enucleation. But for bilateral, of course, we cannot enucleate both eyes. So what we do is we give systemic chemotherapy first, and then we decide. For the worst eye, usually we would enucleate, and then for the better eye, we would keep and then add on local therapy. But in very advanced centers, of course, group D and E, we would try to give globe salvage by giving the intra-arterial chemotherapy to try to avoid enucleation, which I would discuss in detail a bit later. So for extraocular, they would need a combination of chemo, enucleation, and of course radiotherapy as well. So what local treatment can we offer for retinoblastoma? The first local treatments are lasers. There's two types actually. One is photocoagulation, where we give the lasers surrounding the tumor. So what these do is they destroy the blood vessels which supplies the tumor and thus shrink the tumor, as what you can see in the photo below. And then thermotherapy is using infrared laser, where we direct laser on the tumor itself and it will direct kill and shrink the tumor. Cryotherapy is another local therapy where we use a freezing technique, where we freeze the tumor tissue and causing the cell rupture. This is also done locally from the external of the globe using the cryoprobe, and we freeze the tumor tissue. Going on to the other types of treatment is enucleation, as was done in our patient. We can offer this in unilateral cases C, D, or E. Enucleation is removing the entire eye or the entire globe, but we keep the orbital contents in place. So we do not remove the muscles, the fat, and other soft tissue. We just remove the globe. And where the globe is, initially we would just replace with an orbital implant, and then we put the ocular prosthesis in front, as what Dr. Fazlina has described. During the enucleation itself, we must be very careful to do very minimal manipulation because we want to avoid perforation of the globe. And then we really want to harvest a very long optic nerve stump, preferably more than 10 millimeters. So fortunately for our patient, we managed to get 12 millimeters. And then, of course, we send the fresh tissue for HPE studies, and then we insert the ocular prosthesis when the socket is healed. So usually when we're waiting for the HPE result, it's always the nerve-wracking period to see whether there's any high-risk HPE features or not. Because if there is any high-risk HPE features, then we would need to give extra treatment. If there is retrolaminar optic nerve invasion, massive choroidal invasion, more than 3 millimeters as in our patient, then these are features indicated for adjuvant chemotherapy. But if the optic nerve cut is involved and scleral invasion, this would mean extraocular disease, then they would add on radiotherapy on top of the adjuvant chemotherapy. There are other high-risk HPE findings, which include iris, ciliary body, or anterior chamber seedings, but this is not a clear-cut indication to give chemo. We need to look into other clinical findings and discuss with the oncologist and also the parents to see whether would extra adjuvant chemotherapy benefit or we can observe. So chemotherapy, as described, I just want to just iterate for the medical students. So we have systemic chemotherapy, the intra-arterial chemotherapy for globe salvage, and intravitreal chemotherapy is more for vitreous seedings, cases with vitreous seedings. So intra-arterial chemotherapy is a very super specialized treatment where we usually would need the help of the intervention radiologist to give the chemo via microcatheter fluoroscopy guided through the ophthalmic artery. But the patient selection is very, very critical. It is a primary treatment for a non-germline. We must really make sure it's non-germline tumor and unilateral cases. So this can be offered in group C, D, or E for globe salvage in essence to avoid enucleation. But we really must make sure there is no extraocular extension, no optic nerve or massive choroidal invasion, because if we miss this and we just give local intra-arterial chemotherapy without systemic, then the patient would have the risk of metastasis, which would be very dangerous and life-threatening. So patient selection is very critical. In Malaysia, HKL do offer this treatment for some of their patients. So this just is a photo how a large tumor has shrunk into a smaller one after an intra-arterial chemotherapy. And of course, we also have radiotherapy. One of them is a local plug radiotherapy where they may use iodine, which is put in a gold carrier, and it's implanted where the tumor is for about 2 to 4 days until the desired radiation is attained. And it's also not offered in Malaysia, unfortunately. And for last resort, we also have external beam radiotherapy for cases that have failed local or chemotherapy, and in cases where we have extraocular extension. So for our retinoblastoma cases, lifelong follow-up is a must. Usually during the treatment period, we see them every 4 weeks. And then during the first year after the treatment is about every 3 months. And we see them 6 monthly until the age of 6 or 7 years old, and of course yearly after that. Why do we need to see them lifelong is especially to look into any occurrence of secondary malignancies. Especially in patients who had received radiation for their retinoblastoma, they are at risk of getting osteosarcoma, soft tissue sarcoma, and they can also have other organ cancers such as pancreas, kidney, intestine, CNS tumors, and even leukemia. So the risk factors for these secondary malignancies would include the hereditary form, patient previously treated with radiation, and patient who has a history of a secondary malignancy. If they survive, they would then further have a 7-fold increase to get another type of a secondary malignancy. So it's very unfortunate for this group of patients. So genetic counseling is a must because we know there's about 40% of retinoblastoma cases are of germline or hereditary type. So when it is germline mutation or hereditary, they are having the risk of 50% giving the tumor, the mutated gene to the children actually. And once the children has this RB1 germline mutation, it's about 90% that they even may develop the retinoblastoma. However, if the patient only has a somatic mutation, then they do not carry the risk of passing the mutated gene to the offspring. So as a conclusion, if it is actually just an intraocular RB, it is actually quite highly curable, especially when it's diagnosed and treated early. Only when they present very late and it has gone extraocularly, then they would have a poorer prognosis. Okay, multidiscipline management is a must, and this is repeatedly mentioned. We really want to save the life of the patient first. If possible, we try to salvage the eye, and if the patient is fortunate enough, we may even preserve the vision. And patient would need very close monitoring initially, and later on long-term surveillance. With that, I thank you, and we open the floor to any questions. And of course, at the end of this session, we would have a Kahoot session for the medical students.
Thank you, Dr. Safinas. I now open to the audience for any questions. Perhaps before that, I would like to have a quick question for Dr. Safinas. So this patient is actually sporadic or hereditary type of RB?
From the clinical presentation, we think it's sporadic because she presented at the age of more than 1 year. Usually if hereditary, they would present much younger, less than 1 year old, and it's unilateral and there is no other family history. We think it's sporadic, but we did not send for chromosome or a genetic analysis.
And therefore, Prof. Nolia asks, what is the prognosis of this child being a sporadic and unilateral and stuff?
The prognosis of this child, actually, even though it's a grade E, I would think it still would be very good because the corneal invasion, I know, is 3 millimeters. So there is high-risk HPE features, but we add on the adjuvant chemotherapy of 6 cycles. So we're monitoring her, but we're thinking that the child has a fair chance of a good prognosis. It would be a bad prognosis if we would only do the enucleation without the chemo, then definitely the risk of METs would be higher. But because we pick up the HPE findings and add on chemo, so I think the prognosis would be good for this child.
And when you say that these children are at risk of developing secondary malignancies, is that because of the genetic predisposition or from secondary to the chemotherapy? And
it's more of the genetic predisposition because when they are hereditary, the mutation occurs in all the cells because it occurs very early. So when the cell divide, all the cells would have this RB1 gene mutation. So the second mutation to occur could be possible. So they may develop anywhere in the body later on in life. Plus, they are at higher risk if they would have undergone radiation. That's why hereditary retinoblastoma are at risk for secondary malignancies.
Right. And Prof. Nolia further asks, why is bilateral enucleation not done in bilateral retinoblastoma?
Well, it would be very cosmetically not well accepted by the parents actually. So we will in bilateral cases, we first of all would give chemotherapy to try to reduce the size of the tumor. And after we complete the chemo, we would usually enucleate the worst eye. And then usually one of the eye would be a better response. And we may give local therapy further on. I guess there are cases, even though the good eye cannot be salvaged and enucleation may need to be done, but it would not be the primary treatment. We would try to salvage at least one of the eye, but of course, if we cannot, then we need to enucleate as well.
Yeah, so like Dr. Safina say, preserve life, preserve globe, and preserve vision. So as much as possible, we'll try to preserve the vision and globe.
Yeah, but we need to weigh between the risk of mets. If the cells really are not responding, then we may need to enucleate. But I think we give time. Sometimes we don't really straight away do bilateral enucleation. It would be very, very traumatic to the family members. You know, even we want to do one unilateral enucleation, would take a long counseling to talk to the parents before they agree for the enucleation. So if we do bilateral, it would be even worse.
Okay. All right, if there's no further question from the audience, I think we can wrap the session now. Cik Bukhari, would you like nak teruskan dengan Kahoot?
Saya teruskan dengan Kahoot. Lepas tu kita ada untuk MMA punya ni QR code. Okay, thank you. Okay, Kahoot ni untuk medical student untuk medical student gunakan nombor matrik kerana ada hadiah untuk anugerah sanjungan kencana tahun hadapan jadi memang ada hadiah untuk medical student tapi kena gunakan nombor matrik supaya anda dapat dikesan. Terima kasih. Okey, saya akan tunggu dalam kiraan 10 Dalam kiraan 10 saya akan tunggu sebab kita ada webinar selepas ni Selepas ni ada satu lagi webinar. So saya terpaksa jalan dulu. Okay, next saya akan sharekan link untuk pautan kehadiran. Okay, link untuk pautan kehadiran ni semua sekali boleh isi. Untuk peserta di FB saya dah sharekan, ada saya dah pinkan. Borang maklum balas tu adalah juga adalah borang kehadiran. Isi sekali saja feedback form ni. Lepas tu saya akan sharekan QR code ini untuk doktor saja. Okay, terima kasih.
Okay, sementara Cik Bukhari show the QR code, I would like to thank all the presenters and all the attendees for attending this CPC this morning from the Department of Ophthalmology. We would like to express our greatest gratitude to everyone. Thank you very much.
Okey, jadi saya end sesi ni sebab untuk memberi laluan ada webinar selepas ni.
Terima kasih Encik Bukhari dan terima kasih semua. Assalamualaikum.
Terima kasih Prof, terima kasih semua panelis dan attendee.
Thank you.
Thank you.
Thank you everybody.
Thank you.